Let's get rolling. So last time we left off regarding a synovial joint, and I'm going to do a quick verbal review of the structure of that joint, and that includes, the synovial joint includes articular cartilage, which is the hyaline cartilage that coats the ends of the bones of that joint. There's a joint cavity. The joint cavity is what is actually filled with fluid, that synovial fluid, and we talked about the constituents of that last time. There's also what's called the articular capsule. So the articular capsule is made up of a fibrous layer of connective tissue surrounding the synovial membrane. So that synovial membrane is really the innermost membrane that secretes the fluid and contains the fluid. And then just outside of that is a fibrous layer of connective tissue. Together, those things make up what's called the articular capsule. We talked about the fluid inside, and on the outside of that articular capsule are reinforcing ligaments. Those are the outermost ligaments of connective tissue that surround the joint. And finally, I didn't say much about this last time, so I'm going to go to my first whiteboard. And we're talking about synovial joints. I'm not going to rehash the whole thing that we did last time or that I just said, but I did want to say this in particular about nerves and blood vessels in a synovial joint. So nerves innervate the actual capsule. They don't penetrate into the capsule, but they innervate the capsule around the edge of that fibrous connective tissue and synovial membrane itself. And it's fairly highly innervated. There are some pain nerves, I should say pain receptors, in this synovial joint, but mostly we find nerves associated with joint position and stretch receptors. So I'm going to put mostly stretch, comma, position receptors. Okay, if a meniscus is present in the synovial joint, so just to remind you what a meniscus is, it is a pad, a fibrocartilage pad that's separate from the articular cartilage coating the bones. A meniscus is a fibrocartilage pad that, if present, would divide the synovial cavity into two sections. So really quickly, there's a meniscus at the knee. So I'm not going to draw the entire synovial joint, but if those are the femoral condyles, here are the tibial condyles, the top of the tibia. If we find a pad of fibrocartilage in there, which we have in the meniscus right here, that would divide the synovial cavity into a superior and inferior section. Factors that influence stability of a synovial joint. There's three main factors that influence or affect the stability of a joint. The first is articular surfaces. Oops. So what articular surfaces are is the coating of hyaline cartilage on the ends of these bones. That's what articular surfaces are. These do not play a major role in stability. A very minor role in stability is contributed by articular surfaces, but they're more a determinant of the type of movement that the bones or the joint can make. So they're a very small role in stability. The second factor are ligaments. Ligaments do help stabilize the joint. There's fibrous connective tissue creating a capsule here, But then there are ligaments that go from the periosteal surface of bone to bone, like this on the outside, say, of a synovial cavity or joint. Those ligaments do play more of a role in stabilizing the joint, but ligaments can stretch. I think it's like 6 or 7% of their length can stretch, and they can also snap or break if too much tension or stress is put on them. So they play more of a role in stability, but the major role, the primary stabilizing factor, the most important stabilizing factor, is muscle tone around that joint. I put a little star there, so that's the most highest determining factor of reinforcement is muscle tone. So ligaments attach bone to bone, like here. Tendons attach muscle to bone, and there are muscles typically found all around synovial joints, and then tendons help attach those muscles to the bones. And it's muscle tone that is the greatest factor influencing the stability of a synovial joint. All right, let's get on to synovial joint movements. And before I call up an entirely new page, so we're still on this topic of synovial joints. Before I go over type of synovial joints and the movements that they perform, I do want to define 3 terms. Non-axial, that word literally means very little movement on an axis. That's its literal definition. So I'm just going to put very, very little movement. And we say movement in a synovial joint is non-axial if there's only minor slipping of that joint. The term uniaxial means that we do have a fair amount of movement, but it's only in one axis, hence the prefix uni. So I'm just going to write movement in one plane, P-L-A-N-E. Biaxial would be movement in 2 planes. And triaxial or multi-axial are they're synonymous with each other in this context. I believe your book uses the term multi-axial. When I was a student, we were taught triaxial. They mean the same thing. So if I say triaxial and your book says multi-axial, they mean the same thing. That just means there is movement in a synovial joint in all 3 planes of space. Okay, so I'm going to use this nomenclature. I'm going to use this language now, particularly uniaxial and biaxial, occasionally multi-axial, right? When we describe types of joints. By the way, let me go to a new whiteboard here. I'm just going to write this out. Table 8.1, I believe, in chapter 8, gives a pictorial version and descriptions of all of the joint types, the types of synovial joints that I'm going to review right now. Might not go in perfect order of that table, but I'm gonna cover all of them. And I'm just looking ahead. There's 6 total, 6 different types of synovial joints. So I'm just gonna write types of synovial joints. I don't think I'll have time to draw pictures of all of these. Number 1, these are designated planar, or some books just say plane joints. These joints are basically, the type of movement is sliding back and forth. That's the main type of movement that occurs at this synovial joint. Maybe perhaps a tiny bit of rotation is included in planar joints. Examples of these joints would be the wrist bones, the carpals, and the tarsals, the ankle bones, are very typical plane joints. Also the sternoclavicular joint, where the clavicle, the collarbone, meets the sternum at the manubrium. So I'm going to write sternoclavicular joint. The acromioclavicular, which is at the distal end of that clavicle, the collarbone out at the shoulder. So that's acromio. It's all one word. I didn't mean to leave that space. Clavicular. And finally, the sternocostal. Costal means cartilage, sterno means sternum, and it's where the ribs articulate with the sternum. There's a piece of cartilage there that actually, if this is the sternum, there's the manubrium, there's the body. Ribs attach bone to bone back in the back at the vertebral column like this, and then they come forward, and they don't actually, I'm going to draw it articulating with the vertebrae back here. They don't actually articulate bone to bone with the sternum. There's what's called costal cartilage. But that joint of this costal cartilage right here is considered a planar joint. Okay, these typically move, these are typically uniaxial. So let me highlight that. There is a tiny bit of rotation, so a tiny bit of biaxial movement. Now I'm going to move on to hinge joints. These joints, typically, there's a convex surface on one bone. Convex meaning this surface would be convex, and then a concave mating surface on the other bone, which would be this surface. So hinge joints are a convex surface fits into some sort of concave surface. One bone usually remains fixed, and then the other bone swings around that fixed bone, moves around its axis. So these, I'm going to put convex, concave. Those are the surfaces of the two bones at the joint. And typically the concave surface moves around in this direction, the convex surface. But it can be the other way around. It can be this bone moving as well. Just depends on the particular joint. These are uniaxial, so they move in one plane, typically. And the type of joint movement is described as flexion and extension. We went over those types of movements last lecture, what they are, what they literally translate to. Think of flexion and extension movement occurs in all sorts of joints all over the body. The easiest one to picture is the elbow joint, where the humerus meets the ulna. We flex our arm at the elbow, and we also extend it there. Also at the knee is a very typical hinge joint. So let's do some, I'm just going to write quickly. Examples would be the knee, elbow. Those are the two classic ones. But there are others. The ankle typically is a hinge joint that moves in one plane. And the fingers, or technically they're called phalanges. So I'm just going to write phalanges. We flex and extend our fingers at the joints. All right, so we've done planar, hinge. I'm going to call up a new whiteboard to go to the third. Number 3, pivot joints. I just made a quick list on my notes before I started this. So again, this might not be in the exact same order as table 8.1, but they're all here. Pivot joints. Typically, a rounded surface in a pivot joint articulates around some sort of a ring. So I'm going to just write round. This is a description. Round surface moves around a ring type of surface. These also are uniaxial, so they move in one plane. And what we usually get is some sort of a rotation movement, but the examples would be, these are classic examples of where we find pivot joints in the body. The atlas axis joint. Remember, atlas is C1, cervical vertebrae 1, axis is C2. When we nod our heads in a no fashion or action, C1 is actually rotating around C2 on a single axis. So it's rotation only. The radial ulnar joint also does this. So that's, if you hold your arm, stick it out right or left, perfectly straight, and you just turn the palm of your hand upward, you supinate, and then you pronate, turn it back down. Your radius and ulna are actually rotating around each other on a uniaxial rotation only axis. All right, let's go to number 4. These are called condylar, C-O-N-D-Y-L-A-R. Condylar joints, some books call them condyloid. So I'm just going to write that in parentheses. So if you hear me say condyloid, it means the same thing as condylar joint. These are also known as ellipsoidal joints. Anyway, the description is this: a convex projection from a bone typically sits in some sort of a concave depression. I'll be specific with what type of joints these are. These tend to be, let's be consistent here, biaxial. So they move in more than one plane or more than one axis. The movement, just remember, biaxial means the movement is around 2 axes, not just one. Examples would be the wrist joint. Scientifically, that's called the radiocarpal joint. You know, if you hold your arm out, you can move your wrist in more than one plane, not just up and down, that would be uniaxial, but you can also start to rotate it or move it back and forth. So it's biaxial. Another example would be where the metacarpals in the fleshy part of the hand, metacarpals, meet the phalanges. Specifically where that joint is at the base of your finger. So if you hold your hand out and spread your fingers apart, right at the base of your finger where it meets the fleshy part of your hand, you know that you can rotate your finger, keep your finger stiff, but you can rotate the finger at the base in more than one plane. It's biaxial. We can do that pretty much at the 2nd through 5th digits. All right, number 5, we're getting close to 6, all 6 here. Number 5, saddle joints, like a horse saddle. These are all pictured in table 8.1, as I mentioned earlier. They get their name because they're sort of saddle shaped. We have one part of the bone kind of looking like this. I should have drawn that one actually going up so it looks like a saddle. The other one has some sort of a bone that sits in that saddle like this. These are biaxial, so they move in more than one plane or axis. And the classic example of these are what's called the carpo-metacarpal joint. So this is another hand example. I'm just going to write, they get their name from their saddle shape. The carpo-metacarpal joint, we can't really see, but you can feel it. If you palpate the top of your hand at the distal end of your wrist, right where the long bones in the fleshy part of your hand meet those distal carpal bones, those are known as saddle joints. Finally, ball and socket joints. I'm going to call up a new page and write number 6. Ball and socket joints tend to be triaxial or multi-axial. So we get movement in all 3 planes of space. This, you know what a ball and socket joint is, some sort of ball head-like projection. I'm just going to draw the femur, the head of the femur here, fitting into the socket, the acetabulum of the hip, of the ilium, ischium area of the hip there. So the ball projection fits into a cup depression of the socket. They're multi-axial, triaxial. Classic examples are the pectoral girdle. So pectoral, I'm just going to write the shoulder joint, and pelvic hip joint. These joints, ball and socket joints, produce the most movement in the body of all joints. So they create the most movement, but they also tend to be the least stable. So we sacrifice stability for movement. Now the hip joint is much more stable than the shoulder joint, but the shoulder joint has much more range of motion. So whenever you increase range of motion, you sacrifice stability for it. All right, we've gone over the pictures in our last lecture of all of the types of movement at synovial joints and their explanations, things like flexion, extension, rotation, circumduction, all of those things we reviewed. So I'm not going to do those again. I do want to speak about specific synovial joints. Because your book in chapter 8 does spend a significant amount of time on these major joints. I don't know if I'm going in this exact same order of your book, probably not, but I'm going to try to hit all that are addressed. So I'm just going to number these, but it's not necessarily the same order as your book. First one is capital TMJ. That's known as the temporomandibular joint. TMJ, temporomandibular joint, is where the mandible articulates with the temporal bone. That's where it gets its name, temporomandibular. And this is considered a modified hinge joint. Okay, because it has the combined movements of a hinge joint and a planar joint. So I'm going to write hinge plus planar. It's predominantly a hinge joint. When we depress our mandible, open our mouths, the mandible hinges in one plane from that temporal mandibular joint. But you know that you can also slightly slide your mandible side to side in lateral movements. That's the planar part of that modification. So the anatomical components of this joint, I'm not going to try not to go into super detail, so I'm not even going to write this out. But the components are, there's an articular disc, so it does have, this joint does have a meniscus in it. I'm just going to put like the knee joint. So there is a pad of fibrocartilage in there. The two major joints that have menisci are the knee and the temporomandibular joint, TMJ. There's also an articular capsule, just like in a synovial joint, ligaments, all sorts of ligaments, and I'm not going to list those. I do want to list the types of movements that we find. We're going to describe them. We get depression. This is a good review for this language. Depression, I'm going to write /elevation. That would be the hinge part of this joint movement. There's also protraction, retraction. You know that you can jut your jaw forward. That's protraction, and then pull it back. Retraction. Sorry about the writing. There's also lateral displacement. That's side to side in that planar movement. Displacement. And finally, very, very mild rotation, slight rotation. So that jaw, that temporomandibular joint, can do all sorts of things. It's a special modified hinge joint. All right, let's move on. Number 2 on our synovial description, I'm just going to write the shoulder. We know anatomically what that's made up of. It's sometimes it is called the humeroscapular joint or the glenohumeral joint, depending on which book you read. But that makes sense because it's made up of that glenoid cavity of the scapula. That would be the socket, and the head of the humerus would be the ball portion. So I'm just going to write humeroscapular. It's sometimes called that or glenohumeral. Depending on which source you read. The movements, we know that it's a ball and socket. It's multi-axial or triaxial. And sorry about the writing. CK, ball and socket, triaxial or multi-axial, and the specific movements that can be performed at the shoulder joint are many. So I'm going to give you a quick list. We can get flexion, extension, hyperextension, which is extending past the normal part of 180 degrees of the joint. Abduction, just to remind you, that's moving away from the midline. Adduction is moving toward the midline of the body. Medial and lateral rotation. This is the most freely movable joint in the human body. all synovial joints are diarthrotic. I'm just helping you remember some of the language. So there's all sorts of anatomical components made up of this. I'm not going to write them all out again. It's a typical synovial joint that there's an articular capsule. There are all sorts of ligaments. There's a coracohumeral ligament, a glenohumeral ligament, yada, yada, yada. There's a labrum, that excess cartilage around the glenoid cavity. There's also bursa or bursae in the area. I do want to, before I move on to the next joint, because we all hear the term rotator cuff. The rotator cuff is not one specific structure. It's made up of many joints. It's basically 5 or 6 muscles and their corresponding tendons that strengthen the joint the most. Depending on what source you read, I'm just going to write 5 to 7 muscles and tendons that stabilize the shoulder. It stabilizes this joint. Okay, let's do number 3. The elbow. The elbow is just typically a classic hinge joint. And it's specifically, the elbow is where the trochlea of the humerus and the trochlear notch of the ulna that makes up most of this joint. There is some connection with the capitulum of the humerus articulating with the radial head or the head of the radius. That's really, those are the components, most of the components of the articulation. This is, as you know, uniaxial. And main movements are flexion and extension. Right, that's the elbow joint. Dislocation of the radial head is the most common. When we hear about people dislocating their elbow joint, that typically occurs between the radial head and the capitulum. So this part of the joint is what dislocates most often. All right, I'm going to do number 4. We're only going to, there's just 5, so we're almost finished. Number 4 is the hip joint. It's also ball and socket. And what makes up the ball, I've already drawn this, is the head, is the femoral head, the head of the femur, and the socket is the acetabulum of the hip joint. The movements that are involved, first I'm just going to write multi-axial. And the typical movements are flexion, extension, abduction, adduction. Remember, ab is moving away from the midline, ADD is moving toward the midline. Lateral and medial rotation. This is also a very diarthrotic, highly diarthrotic joint, very movable. And finally, circumduction. I can't remember if I wrote that about the shoulder, but of course the shoulder also circumducts. So it has a much more limited range of motion than the shoulder. I'm just going to write limited compared to shoulder. But as we stated several times, that increases its stability. So I'm just going to write more stable. And number 5, last one, is the knee joint. The knee, sometimes referred to as the tibiofemoral joint. So I'm just going to write that in quotes. They all have scientific names based on the bones, the major bones that make up that joint. In this case, the femoral condyles and the tibial condyles make up the knee joint. This joint is the largest and most complex joint in the human body. It's not the most movable, most freely movable, but it is the largest joint and the most complex. Believe it or not, where in the hip joint, that's actually smaller than the knee joint in size and in mass. This is considered a modified hinge joint. Most of the movement is uniaxial as a hinge joint, but I'm going to write modified hinge joint. Basically, the knee is made up of 3 joints within a single synovial cavity, and I'll explain what I mean by that. Those 3 parts, I'll just list them as 1, 2, and 3. The first would be a lateral tibiofemoral joint. The second part of this very complex joint is a medial tibiofemoral joint. So lateral means on the outside of your knee. Medial means the inside part of your knee. Tibiofemoral or femoral joint. And the third component of this large complex joint is the patellofemoral joint. This joint contains the largest meniscus in the human body. The word meniscus literally translates to crescent, and that's because of its crescent shape. Knee meniscus tears are not that uncommon. We can get a tear in that fibrocartilage, which causes a lot of pain and limited mobility. Before I leave the knee, I don't want to call up a new whiteboard. I'm just going to do the movements over here to the side. So we're talking about the knee joint. The movements would be flexion, extension. Those are the main major movements of that modified hinge joint. Slight medial rotation. You know that you can, there is very slight rotation in your knee. So flexion extension is not, it's not truly uniaxial. There is slight medial rotation and slight lateral rotation as well. But by and large, it's mostly flexion and extension. Okay, that's what I had on tap for today. Before we totally leave, I do want to get you started. I might come back tomorrow and do a finish up, really super short, quick lecture on this. But I'm just going to write injuries / disease. I don't have time to cover all of these today. I did want to talk the difference between a sprain and a strain. I'll just get you started on this. This is the very end of the chapter, and I'm not intending for you to just gloss over this or blow off the end of the chapter. I will come back and talk more about this. A sprain tends to be much more serious than a strain. Sprains at a joint is actually a stretched or torn ligament. So stretched. Typically more painful and takes longer to heal than a strain as well. It creates a huge amount of swelling when we have a sprain. The most common area of a sprain is, excuse me, the lateral ankle and the wrist. So the carpals and tarsals. Strain is not quite as serious of an injury, and that is typically a torn muscle, tissue, or tendon. It tends to have not zero swelling, but I'm just going to write compared to a sprain, less swelling, typically faster to heal as well. Okay, I'm going to cut my recording here. And like I said, I'll probably have time to do another quick finish up on diseases. I'll talk about arthritis, different types of arthritis. So let me cut that.